Good afternoon, everyone, and thank you for joining us for this week's National Bleeding Disorders Foundation, formerly National Hemophilia Foundation, Wednesday webinar. My name is Fiona Robinson, and I am the series host. Today, we will learn about the burden on parents of children with moderate or severe von Willebrand disease, the impact of clinical data. Please feel free to ask any questions you may have throughout the presentation by using the Q&A feature at the bottom of your screen. We will monitor these questions as they come in, and I will put them to our speakers at the end of their presentation. This webinar is being recorded and will be available to the community beginning on Friday, September 22nd. Today, we have two speakers from Gothenburg, Sweden, Dr. Anna Olsson and Dr. Linda Myrin Westesson. I'd like to thank them both for joining us today. We'll get started now with their presentation.
Thank
I think we're having a problem with the audio. I'm very sorry for that. I'm going to try again to share the video.
you for the invitation. Study on caregiver burden on parents of children with von Willebrand disease in Sweden. My name is Anna Olsson, and I'm a hematologist, and my research colleague is Linda Myrin Westesson, who is
just going to stop now. I want to double check that you do hear. I'm getting a message that you are hearing the audio now. Okay, I'm going to start
a registered
again.
nurse
Sorry about that.
specialized in bleeding disorders. Our publications on burden on parents of children with moderate and severe von Willebrand disease. We have studied the impact of clinical data and psychosocial aspects on caregiver burden. The research was supported by an investigator-initiated research grant from Takeda, Sweden. We have no other conflicts of interest to disclose apart from that grant. First, we would like to give you a short background to von Willebrand disease, to the term parental burden, and also to the Swedish welfare system. An understanding of the welfare system helps to put our results in a context. Now, as you know, von Willebrand disease is the most widespread congenital bleeding disorder and von Willebrand disease is clinically affecting approximately 1 in 1,000 persons. The symptoms of von Willebrand disease are characterized by mucocutaneous bleeds, such as hematomas, nosebleeds, and bleeding after surgery and dental extractions. Also, women and girls with von Willebrand disease frequently report heavy menstrual bleedings. The aim of treatment in von Willebrand disease is to stop an ongoing bleed, to prevent bleeding and disabilities, and to enable participation in physical and daily life activities. Treatment also prevents bleeding during surgical and dental procedures. The treatment for a specific bleed depends on the von Willebrand disease subtype, the bleeding phenotype, and the severity of the bleed. From the time a child is diagnosed with von Willebrand disease, the parents are highly involved in the recognition and evaluation of bleeds and treatment options. Von Willebrand's disease impacts on the health-related quality of life of children and adults. And the quality of life of the person with von Willebrand disease is strongly associated with the bleeding phenotype. Managing daily family life with a chronically ill child means that, to some extent, as Anna said, the parents need to be an active part of the treatment. One consequence of the child's illness is personal suffering for the parent. This parental suffering is termed burden in research. Parents of children with von Willebrand may face a multitude of practical and psychosocial demands. The child needs extra supervision and care, treatment, and regular hospital visits. Parents need knowledge about disease management and how to recognize and treat a bleed. Furthermore, the parents may need to reduce working hours and have difficulties with childcare or high medical costs. Parental burden includes both practical and psychosocial aspects. The need to evaluate the specific burden on caregivers of children with von Willebrand disease has recently been addressed. Generic instruments designed for use across different diseases and ages to measure caregiver burden are available. However, disease-specific instruments are much less common. Disease-specific instrument can be considered as being more sensitive to the consequence of the specific disease. In this case, the bleeding disorder, the von Willebrand disease. I will try to explain the context of the study we have done in the next slides. Sweden is a country in the up north of Europe, as you see here in the map of Europe. We are to the area a large country for being in Europe, but with a very small population of only 10.5 million people. Sweden has 3 big cities, not big if you compare to the US, but big for being in Sweden. Stockholm is the biggest and also the capital of the country. Gothenburg or Göteborg, where we live and work, Anna and I, are the second largest city of Sweden and is located on the west coast towards Denmark. And in the south, we have Malmö. The 3 comprehensive care centers of Sweden are located in these 3 cities. So like it is in the States, Swedish patients and families sometimes travel a long way for the annual checkups. We have a Swedish national register for bleeding disorders. The purpose of the national register is to get a good follow-up of this group of patients and to improve quality of care. The most important measures when evaluating the treatment is the occurrence of bleeds per year, joint injuries and other serious bleeds, quality of life, and psychosocial aspects. And here you see the numbers of patients we have in Sweden divided by diagnosis. So what it says here under hemophilia is mild, moderate, and severe. And under von Willebrand, it says type 3, type 2, type 1, and other. We have a total, as you see, of 962 von Willebrand patients in the register. The national registry has a cover rate of 94% for von Willebrand patients, and one can suspect that some mild von Willebrand patients are not in the register. To put more of a social and cultural context, like Anna said about the study results, now that we know where Sweden is located on the map of Europe and the number of von Willebrand patients we have in the country, I would like to explain a bit more about how the medical system works and about the welfare system. The Swedish welfare system is well-founded compared to many other countries. The parental leave insurance system consists of 480 paid days per child. It can be used until the child becomes 12 years old. 3 months of this parental leave is reserved for only being used by the father, and another 3 months can only be used by the mother. Medical care, medications, and treatment is free of charge for children under 18 years of age. If the child is sick or needs medical care, parents are compensated for loss of salary by the welfare system, and the employer cannot deny leave. Child allowance is a financial support that is automatically paid out to all parents who live and have children in Sweden. But if the child has a disability or a chronic illness, like von Willebrand's disease, the parents can apply for extra child care allowance. The extra child care allowance compensates for extra supervision, care, and expenses. For example, for treatment at home, trips to the hospital, or special furniture. I think that knowledge about the welfare system is important to have in mind when we later look at the results of the study. All children aged 1 to 5 years old have a guaranteed place at preschool. The fees are subsidized by the government, and parents only pay a fraction of the actual costs. In Sweden, 84% of children between 1 and 5 years old attend preschool. In the school system, children go to school for at least 10 years from the year they turn 6. Children between age 6 and 13 are also offered out-of-school care before and after school hours. Gymnasium, or as you call it, upper secondary school or high school, the year 10 to 12, is on paper optional, but almost all teenagers attend. School for all ages, including college and university, are free of charge. In Sweden, it's standard that both parents work. So after we have talked a bit about the social context, I come to the aims of the study and why we wanted to do it. So we found that little is known about the perceived burden of parents of children with von Willebrand when we looked in the literature and tried to find research. Increased knowledge generated from this study may be beneficial in developing a more structured way of supporting parents of children with von Willebrand, and thereby improving the care of families affected by von Willebrand. So the aims of the study was to describe the pediatric population with moderate and severe von Willebrand in Sweden, to explore the impact of the child's medical condition on parental burden, and to explore the impact of psychosocial aspects on the parental burden. Now we come to the methods of the study. This was a multi-center, cross-sectional study conducted at the 3 hemophilia centers in Sweden, in Stockholm, Gothenburg, and Malmö. A cross-sectional study means that you look down and take like a snapshot on how the situation is right now. You don't follow the parents over time. And as I said, all 3 centers were included, and the study was approved by the Swedish Ethical Review Authority. Parents were included between October 2020 and November 2021. study information, informed consent form, and 3 questionnaires were sent by post. Parents of children aged 0 to 17 years with type 1 von Willebrand with a von Willebrand factor activity under 20%, and parents of children with type 2 and type 3 von Willebrand could be recruited. So we included parents of children with moderate and severe Willebrand in the study. 105 families with children under 18 years were identified in the bleeding disorder registry. A questionnaire specifically developed for the study was used for the collection of psychosocial and socio-demographic data. Parents were asked about age, living situation, education, marital status, work, number of children with and without von Willebrand, and other chronic diseases of children and parents. The study-specific questionnaire also included questions about how von Willebrand disease impact parent, family life, time to treat, absence from school and work, family economics, and physical activity. Clinical data about the children were collected from the Swedish National Registry for Bleeding Disorder. This included type and severity of von Willebrand, treatment, and bleeding history. We also used the instrument HemoCab, and I will go through that in the next slide. The HemoCab is called the Hemophilia Associated Caregiver Burden Scale, and is a evaluated scale that assesses the burden for caregivers or parents of children with bleeding disorders and has been used in several studies. The HemoCab instrument consists of 52 questions divided into 12 domains, and I will go through the domains now. Emotional stress for the parents due to the child's illness is the first domain. Financial burden for the family due to the child's illness is the second. One domain is personal sacrifice and limitation due to the child's illness. Furthermore, job-related burden due to the child's illness. This is, for example, if the parents miss a lot of working days. Interactions with others covers social contacts if they are affected by the child's illness. And the domain interactions with siblings is about if the parents have enough time for healthy siblings. In the domain school, the questions are about if the parent is safe with the child's school or preschool. Perception of child is how the parent experiences the child's need. And the domain dealing with the child's bleeding disorder is about if the parents feel that she or he can deal with the child's bleeding disorder in an okay way. And medical management, this domain is question about the treatment burden for the parent. Work situation related to the child's bleeding disorder is, for example, if the parent had to be physically close to the child. And the last domain is the impact of the child's bleeding disorder on the parent's life in general. The score on each domain range from 0 to 100. A higher score indicates a greater burden. The instrument has previously been evaluated and translated into Swedish. In the Swedish version of the HemoCab, the word hemophilia is translated into bleeding disorder. The HemoCab instrument includes 2 questions specifically aimed at female carriers about the consequences of X-linked inheritance. In the present study, the 2 questions were bypassed the same way as if a father to a child with hemophilia would answer the questionnaire. As I mentioned before, there are no disease-specific questionnaire for parental burden for von Willebrand. HemoCab was the best evaluated questionnaire that we could find to enable measuring the specific burden of being a parent to a child with a bleeding disorder. The parents choose themselves who should participate in the study. If the parent had 2 or more children affected with von Willebrand, clinical data were collected from the youngest of these. Of the 105 families, 70 parents completed the questionnaires with a response rate of 67%. Non-respondent parents, they were only 35. The parents had a median age of 9 years, and the types of von Willebrand had the same spread as included parents. Like in most studies on parents to children with illnesses, a majority of the participants were mothers, 70%, and the median age of the parents were 40 years. And I want to mention as well that only one parent per family could be included in the study. So Anna, please.
Yes, now I'm going to present the results of the study. And first we have the socio-demographic characteristics of the participating parents. And as Linda said, the median age of the responders were 40 years, ranging from 28 to 54 years. And the majority of the respondents were mothers, and the majority of the parents reported that both parents took care of their child together. Most of them were also married or cohabiting. 70% of the parents had a college or university education, and almost 70% of the parents also worked full-time. And here are the characteristics of the families of the participating parents presented. At the top, the number of children in the families are shown. Most families consisted of up to 3 children. And below are the number of children with von Willebrand disease in each family presented. In 60% of the families, there are 1 child with von Willebrand disease, and in 30% of the families, there are 2 children with von Willebrand disease. Almost half of the responding parents had von Willebrand disease themselves, and there were all other family members, such as grandparents and cousins with von Willebrand disease in the majority of the families. A chronic illness besides von Willebrand disease was present in 10% of the responding parents. The chronic illnesses included rheumatoid arthritis, Crohn's disease, Bechdrev's disease, and ulcerative colitis. And these are the clinical characteristics of the children with von Willebrand disease. The median age of the children was 9 years, ranging from 0 to 17 years. There was almost an equal number of boys and girls. A majority, almost 70% of the children had von Willebrand disease type 2, 20% had von Willebrand disease type 1, and this group is small because, as we mentioned, we included von Willebrand disease type 1 with less than 20% von Willebrand factor activity. About 10% of the children had prophylactic treatment with factor concentrate, and those were mainly the children with type 3 von Willebrand disease. About 60% of the children had ever been treated with factor concentrate, and the same number of children had been treated with desmopressin or DDAVP. And below, there is the reported number of bleeds in the past 12 months. About 1/3 of the children did not report any bleeds. 1/3 reported 1 to 5 bleeds in the last 12 months, and almost 1/3 reported 6 to 30 bleeds in the past year. A small number of children reported more than 30 bleeds in the past year. 1/3 of the girls who had reached menarche was treated with hormonal therapy due to heavy menstrual bleeds. Almost 1/5 of the children had been treated for iron deficiency during the past year, and as many as 1/3 of the children had been admitted to hospital due to von Willebrand disease during the past 12 months. 10% of the children had another chronic disease, including epilepsy, diabetes mellitus, ADHD, and allergy. Now here we present some clinical characteristics of the children divided into the different subtypes of von Willebrand disease. So there are a few children in each group, but we still think it's interesting to present.
The median age of diagnosis was lower in type 2 and type 3 as expected. In type 3 von Willebrand disease, a majority of the children was diagnosed due to a bleed rather than to hereditary reasons. The annual bleeding rate was higher in children with type 3 von Willebrand disease, even though most of them were treated with lactic factor concentrate. Some of the children with type 1 and type 2 von Willebrand disease reported a very high annual bleeding rate, as you can see. The median age at first treatment was less than a year in children with type 3 von Willebrand disease. The median age was higher in type 1 and type 2. At the bottom line, the number of children who had been admitted to hospital care due to von Willebrand disease during the past 12 months are shown, and the numbers are fairly high. Now I will show 3 slides with the results of the hemoglobin burden scale. The first slide shows the results of the parental burden based on the child's clinical status. Parents reported a significantly higher burden if the child was diagnosed due to a bleed rather than to hereditary reasons. The parental burden was also significantly higher if the child had 1 or more bleeds in the last 12 months. And the parents of children who had prophylactic treatment with factor concentrate also reported a significantly higher burden. The second slide showed the hemoglobin results of the burden based on psychosocial aspects. Parents reported a significantly higher burden if von Willebrand disease had an impact on what the parent allowed the child to do. The parents stated that these limitations applied to the child's participation in physical activities and sports. Parents reported a significantly higher burden if the child had been absent from school for 2 or more days in the past 12 months due to von Willebrand disease. And the parents also reported a significantly higher burden if the child's von Willebrand disease affected their own life in general, and if the child's von Willebrand disease had a financial impact on the family. There was no significant difference in burden measured by hemoglobin between parents of sons and daughters, and no difference in burden between parents with children in different age groups. And there was no difference in burden if the parent had von Willebrand disease themselves or not, and not a difference in burden between parents of children with different types of von Willebrand disease. Even though our cohort of parents is rather small, we would also like to present some differences between boys and girls reported by the parents. The girls had an average of 5 days absent from preschool and school in the last year, and the boys had an average of 1.8 days absence due to von Willebrand disease. The differences between the girls and boys were even larger in the group of children aged 11 to 17 years. The girls in that age group had an absence of 5 days and the boys 0.5 days in the last 12 months due to von Willebrand disease. Also, as a consequence, the parents of girls report a higher frequency of absence from work due to the child's von Willebrand disease. My last slide on the results showed the reported impact of the child's von Willebrand disease on family life. 1/3 of the parents, the fathers to a little higher degree than the mothers, reported that the child's von Willebrand disease had affected their lives in general. Half of the fathers and 1/3 of the mothers reported that the child's von Willebrand disease had impact on what they allowed the child to do. These limitations apply to the child's participation in physical activities and sports. And 10% of the parents and 1/5 of the fathers reported that von Willebrand disease had a financial impact on family life.
Now I will repeat a bit of what Anna just said, but in conclusion, parental burden for parents of children with moderate and severe von Willebrand is affected by the child's clinical status. The presence of bleeds, prophylactic treatment and diagnosis due to bleed increased the burden. No significant difference in parental burden was reported between the subtypes of von Willebrand. The parental burden was also affected by psychosocial aspects. Aspects that affected burden negatively were if the parents reported that the child von Willebrand affected their life in general, if the child was absent from preschool or school, if von Willebrand had an impact on what the parent allowed the child to do, and this was mainly in physical activities like Anna said. Similar results were found in parents who reported that von Willebrand had a financial impact on the family. So the bring home message from our study is that clinical follow-ups should include psychosocial aspects to identify parents that are at risk for high burden. Awareness of the teenager girl's bleeding situation is needed to provide equal care between boys and girls with von Willebrand disease, and that healthcare professions need to be aware of the increased parental burden associated with frequent bleeds. Thank you all for listening and for inviting us to speak today.
Thank you.
Thank you very much, Anna and Linda, for that very interesting presentation of your study design and results. Dr. Olsson and Dr. Myrin Westesson are here with us live to answer your questions. So if you have any questions for our guests, please do put them into the Q&A feature at the bottom of your screen, and we will do our best to answer all of your questions. I'll start with a question that we have received asking a little bit more about the situation in Sweden in the school system, whether there are specific regulations for children with chronic diseases to assure that all of their health and educational needs are met. I think there are some sort of parallels in the US with the IEPs and the 504 plans. Is there something in Sweden in the school system that is actually a regulation to ensure that their health and educational needs are met for children with chronic disorders?
Yes, one could say that the children should be having all the assistance they need to have a regular school pathway. So if you have a child with like a inhibitor, for example, with hemophilia instead of von Willebrand with inhibitors, you have an assistant at school and things like that. So, but with the von Willebrand disease, there is, I don't know if any of our children, our patients that are children, do they have the need for that? So they have just a regular school way. And it might be that they have extra care before and after school, that they need to be an extra teacher there, because usually when accident happens is after school when the kids play. Yeah.
Yes, can I add, because there are laws to make sure that children with chronic diseases get the same education and possibilities that the other children, if you just don't talk about bleeding disorders. So
okay, yeah, so more generally, yeah. Maybe I could ask a few questions about the HEMOCAB, the Hemophilia Associated Caregiver Burden Scale. You mentioned that it was translated and validated in Swedish. Do you know what language was it developed in, and is it available and validated in any other languages?
It was developed by Professor Sylvia von Mackensen in English, and I think it was made in the US actually. And it's available, I think, in Turkish, German, and Polish and Swedish, if I remember right now. Yeah, and I did a work with it a few years ago when I evaluated and did a pilot study and tried to evaluate it towards Swedish. And it's a bit complicated when you translate instruments, patient-reported outcome instruments, because the word you use in English they are not the same in Swedish. You need to do a cultural adaptation as well. So you see the word hemophilia in Swedish is bleeding disorder. So it's complicated because the words don't match right over. So that's why, and that was the best instrument we could find to catch the burden of parents to children with bleeding disorders. And I think one way to go is to develop a specific questionnaire for parents or caregivers on all ages for persons with von Willebrand disease.
Yeah, did you have any feedback from the parents about that survey and how well they felt it really reflected or captured their experience?
Yes, we did. And when a survey like this is made, it's supposed to work across the globe. So it should work as well in South America and in Africa and things like that. So it's a lot of questions that maybe don't suit our society, but that's what it comes with if you want to compare results from different cultural contexts. So some of the parents said that there was a lot of like very sick questions that doesn't apply to us. Yeah.
Interesting. That's very interesting. I noticed that most of the parents said that they both took care of the child together, but the majority of the survey respondents were mothers. Do you think that there's any asymmetry in the care for the child? If they're sharing the care, is there any indication to you whether that's a fairly equal sharing or whether the burden tends to fall more to the mother or the father? Or is that beyond really what the survey asked?
It must be beyond what we asked, because all the results we present are from the respondent. Everything about the bleedings and so we only had the answers to what we asked, and we just asked those straight questions.
Yeah.
So we don't really know, actually.
One thing that I think is interesting, it was actually the fathers that reported that they were more, they did not allow the child to do so much. The mothers allowed the children to do more. And the fathers also reported that they had a financial impact on the families and that it affected their life more than the mothers. And I think that's very interesting. And I think as a researcher on families with bleeding disorder, I really want to encourage all the fathers to participate in the studies, because we need the results from the fathers, because there are a lot of that is missing in research even today.
And it does seem to be a distinct perspective.
Yeah, it does.
Interesting. Someone is asking here, could you explain why the clinical data was only collected for the youngest child? If a family had multiple children with VWD, why did you only collect data about the youngest of those children?
Well, we only wanted one child from each family because of the statistics to be able to present the results in the best way. And we took the youngest child because I think that's isn't it? Didn't we talk like that about that, Linda? That's the way it's mostly done in this kind of studies, that you take the youngest child. We wanted to make sure we did the same thing in every family, of course, also.
And also I've done a previous study where we looked at the caregiver burden of hemophilia, and then we saw that the younger the child was, the higher the parental burden was.
Okay.
But we didn't see this in the study, but we saw that in that. So that was the hypothesis we had. We wanted the youngest child. Besides the statistic reasons, Anna said.
Yeah. What was your response rate like for the survey? I'm not sure if we talked about that. What was the rate of response as you sent the survey out or administered the survey?
67%, wasn't it? If I remember right. Yeah. I think so. About 60 or something like
that. Your data showed that the children were diagnosed at quite a young age, less than 2 years. One of the questions that we had about that actually was to say that in a lot of other countries, the median age of diagnosis is a bit higher. Is there something, could you tell us maybe a bit more about the diagnosis pathway in Sweden, and if you think there's anything that's maybe helping with this earlier diagnosis?
I'm not sure, because I think in all countries you do test the small children in a family of von Willebrand disease, don't you? I'm not sure why it's earlier in Sweden.
Is it largely based on a sort of a family history in Sweden? Is that sort of how the pathway that you follow in the diagnosis?
Yes, but there are the one with type 3. They would come for a bleeding perhaps since they don't have it in the family. But otherwise, we do take blood samples when they are around 1 year or something like that, if they have von Willebrand in the family.
Yeah. Did you look, or did you notice if there was any difference between the age of diagnosis for female versus male children? Maybe not at such a young age, but I know in the literature there are experiences of differences in the sort of the delayed diagnosis between females and males with VWD. I don't know, did you notice that with your young children?
No, we didn't do that. Sorry, Anna.
No, we didn't. It was the same age between boys and girls.
And then,
but they were not that many. It's also a small study, of course.
Yeah. And I mean, you're catching them very young, so it's the chances for a delay there are much smaller. Yeah. You mentioned also the difference between the amount of time that's missed from school between the boys and the girls, and then especially in the teenage years. Maybe I just ask you, do you have a theory as to what might be behind that?
Yes, Anna, you were not unmuted. But yes, we think it's the female type of bleeding, so it's menstruation bleeds. So,
and is there anything maybe then that could be done to support that better, or something to maybe try to mitigate the impact that this seems to be having?
Yeah, I think we really need to think about this as healthcare professionals, how often we take in the female bleeders, and how we treat them as well. And this is something we need to look further into. But I would think it has to do with that. We didn't clearly ask that, but that's basically the obvious reason. So it's something that really needs to be looked further into. And also, I don't by heart know how the difference in school absence between girls and boys are. I think that girls are a bit more absent in Sweden, but this question was actually direct due to von Willebrand. So I think we're not catching that. I think it is actually the menstruation bleedings.
Right. Yeah. I think it was interesting that there was not a difference in the burden reported, if I understood correctly, between the different types of VWD. I think we sometimes think of them as having different severities. And was that something that was a surprise to you, or what did you think of that they sort of all came out the same?
No, that was a bit of a surprise. We talked about if we would do this again, we would also include the ones with milder forms of von Willebrand to have a bigger spectra of the disorder. And maybe then we would catch that, because these were, we say moderate and severe, but they are not, they have low factor levels, and the type 2 and really low type 1. So maybe that's one of the reasons why we didn't find any difference.
Yeah, because you had a factor level cutoff, didn't you?
Yeah, 20 at 20.
Yeah.
So if we would do it again, we would include everyone up to 35%.
Yeah, I think in a way you may be answering a question that we've just had come in from the audiences, is whether the lack of difference in the burden and the severity could be due to the rarity of the type. That sounds like really kind of what you're thinking there.
Yeah.
We have another question come in asking about the supports that parents would receive from hemophilia treatment centers in Sweden. For example, are there social workers to provide resources and support to sort of help alleviate some of this burden?
Yes, we have social workers connected to the centers, and they are meeting the families when they are newly diagnosed, and then they meet them on referral of the nurse or the physician, or if the parents ask for it, and they can also contact them directly.
And from the results of your study, are there any suggestions that you would make to changes or additions that could be made to supports for parents? Are there things that you can see that could be expanded upon or added?
There was one thing that surprises us was that so many of the parents restricted what the children could do, and that was mostly regarding physical activities and sports. So I think it's important to bring that question up when the child is very young and say that we can adjust the treatment so your son or daughter can be physically active like another child. And I think we need to bring in this quite early so the parents allow and promote physical activity, because like any other child, physical activity is very important for children, even if they have a bleeding disorder, of course. So I think that's something we need to work with. And we have actually tried to introduce that more in our center. So we bring it up at an early age and be positive to all candidates. They don't have to be organized physical activities, but just to promote it for the child's health.
Great, thank you. That concludes the questions that we've received from our audience. So thank you very much, Anna and Linda, for answering those. I'd like to thank Dr. Olsson and Dr. Myrin Westesson for taking the time to join us this afternoon. We really appreciate your time and your expertise. I'd like to also thank each of you in our audience for joining us today. This recorded webinar will be available on Friday, September 22nd at hemophilia.org under the Events tab. If you select past events, you will find all of our archived webinars there. Also available in the Events tab is the schedule of upcoming webinars in the series. Please join us next week for an update on federal telehealth policy from the American Telemedicine Association. Thank you for joining us this afternoon and have an excellent week.